me, and I hope that after this presentation that I give, you'll feel more comfortable during your own exams, and please pardon my dog walking around in the background, more comfortable with advocating for yourself during your own exams, as well as hopefully asking questions at the end, so I can hope better answer anything that I didn't cover specifically during this talk. Before we get started, I'm going to say that we have a couple of prompts that will be, I guess I'll reach out to Nicole when those are ready to be released. So please feel free to answer those. And then I'm happy to take questions during this or at the end. If you do have questions, I think the plan was to put them in chat or send them to one of the MCs so then they can read them aloud for everybody to hear the question, and then I can answer. So if you want to, Nicole, break when a question comes up, I'm happy to pause, or if you'd like to wait to the end, that works for me as well. So I have my notes next to me. You might see me kind of looking off to the side. Now I'll share my screen and then I'll put this presentation up. Okay, perfect. So today we'll be talking about the trauma-informed well-woman exam. And I think a big thing to talk about is a well-woman exam does not necessarily mean a pelvic exam. So a pelvic exam is a physical exam. It can be a component of the well-woman exam, but oftentimes well-woman exams don't include any type of physical exam if you don't need anything or don't have any particular symptoms that we're trying to find a cause for. There we go. And there's my disclosures. So no financial disclosures, but as Nicole mentioned for me, I did put up information about both of the, or I guess the 3 locations that I trained, including the Hope Clinic in New Orleans, which is part of the Family Justice Center, and then Planned Parenthoods in both Louisiana, New Orleans, Louisiana, and Vista, California. So what does trauma-informed mean? Trauma-informed is something that a lot of people have been advocating for, or I guess I should say a lot in a niche group of people have been advocating for a very long time, and is now just becoming mainstream as our culture is shifting towards kind of reevaluating how we handle all kinds of things, particularly people who are historically exploited, like the LGBTQ community, as well as our Black and Brown sisters, brothers. So trauma-informed means safety. So do you feel safe in your exam? Do you feel safe in that room with your provider, whether that's a physician, a midwife, a PA? How do you build trust? That's something that is important for us as practitioners to know how to do, because oftentimes we only have 15 to 30 minutes with a patient. And I'm sure that you as patients are seeing that, and you're seeing where we're very pressured to try to get the answers out of you. So how do we build trust, get the information we need, make the determination for what needs to happen during that 20-minute appointment slot, and go from there? Empower is important for lots of people to make sure that a patient is empowered. So part of the reason we have chaperones is to make sure a patient has a third-party witness during any sensitive exam to help empower that patient to speak up if something's not going as they think it should be going. Collaboration, so collaboration with the patient, understanding their history. Cultural sensitivity, so the nuances of someone coming into a room and how does a dynamic shift with gender differences, with race and ethnicity differences, with age differences, and better understanding that cultural sensitivity component that is a part of any exam. And then healing. And you guys are all doing the work today on your own healing. So that's important. It's important that you're working on your own healing so then you can be a better advocate for yourself. So I just put some definitions up here so everybody understands where I'm coming from and where the trauma-informed physicians and practitioners are coming from. So woman, any person who identifies as a woman. Something important to note is transgender men who retain their biologic organs still require pelvic exams as part of routine cancer screenings, and can still have symptoms like anyone else with cervix, uterus, ovaries. So they would still require pelvic exams for those things, but would not necessarily identify as a woman. Capacity. So this is also known as decision-making capacity or competency. So when you're talking to a patient, are they altered in any way? Are they, whether by some diagnosis like dementia or some form of mind-altering substance that they may have taken, been given. So they need to make sure that, or as a practitioner, we need to make sure that that patient has capacity and competency to understand what is going to happen during an exam, and then informed consent. So it's making sure that we, as the practitioners, explain what's going to happen before it happens. And a lot of times, this is something that does not happen before pelvic exams. And I'm sure, unfortunately, most of us here have experienced that, because the assumption is you've had it once, you know what's going to happen, we need to move, get things going. And that's not appropriate. Every time you're planning to do a physical exam on a patient or touch a patient, you need to make sure that you at least verbally ask for informed consent and confirm that that patient has given it to you. So what are the types of sensitive exams? Today, we're focusing on the pelvic exam, but I wanted to put all the other types that are in here that you could get at any time during your well-woman exam or any other type of visit with a practitioner. So pelvic exam, we always think about, and before I lift this up, I'm going to let you know, I'm going to show speculum. So this is an unused speculum that I use for training to teach med students and my corpsmen about how to perform a speculum in the least invasive way. But a pelvic exam could include a speculum, but also it could just be manual or digital meaning fingers. Obviously, we would have gloves on during that procedure. But when someone says pelvic exam, the type of exam you're going to do is going to be dependent on the concern and the other whole history of what's going on with that patient. Breast exam is also considered a sensitive exam. It's also an exam that should have a standby or a chaperone in the room while you're doing it. Something to note here is there's been a big shift in how we present breast exams and who needs them. So mammograms came along and they are incredibly good at finding abnormalities and things that need to be followed up with, either a breast surgeon for biopsies and things like that. But what we found is that a doctor who is seeing you for one time doesn't really have a good diagnostic sensitivity to be able to find something that's abnormal. So if you're coming in without any breast complaints, and you don't have anything specific that you wanted the doctor to look at on your breasts, we no longer require it as part of the annual exam, just because ultimately the mammogram is going to do a much better job than any human at finding something abnormal in an asymptomatic person. But if you do have concerns for any type of lump, redness, abnormality going on with your breasts, then a breast exam would be warranted during that visit. Rectal exam. Rectal exams are very common for any type of concern regarding blood in your stool. Usually rectal exams, there's internal versus external. So sometimes we just need to do an external exam, spread your butt cheeks and look for something that could be causing that bleeding on the outside, such as hemorrhoids or a fissure. But sometimes internal is also warranted. And again, that means with our fingers, we would be gloved and you would have a chaperone for either an external or internal rectal exam. And then there's cervical checks. Anyone who has been pregnant knows what a cervical check is. It is a manual or digital exam that's done typically during the third trimester when you get close to delivery, that helps us determine how you're dilating. So if your cervix is dilating, how much it's dilated, and we're going to be checking it regularly during your process of labor. That's not something that we're going to focus on today, but that is one of those sensitive exams. So if we're going to be talking about gynecology in general and the pelvic exam in particular, I think it's incredibly important to talk about the history of gynecology. You can read what I have on this slide, but ultimately this is a picture of 3 enslaved women, Lucy, Betsy, and Anarcha. And they were the 3 women who Dr. J. Marion Sims performed most of his gynecologic experimentation on. And so they were, not given anesthesia. They were repeatedly having to undergo procedures that were incredibly painful and things that they did not require. So there was no indication for. So understanding the context in which gynecology came about as a specialty in medicine, it helps us put in context and better understand why we're still having so many issues with understanding women's pain, understanding women's voices, and advocating for women in particular in gynecology, as well as women as a whole in medicine. And I just wanted to put this up as well. This is something that was recently released. I think there's a lot of great things going on in medicine. I was really lucky to be at Tulane, and I'm really glad that I chose a civilian school to kind of shift my mindset and get out of the military for a while and have those 4 years of medical training be somewhere else with, I would say, less indoctrinated thought processes. And there's a lot of grassroots kinds of projects that are going on now within medical school, and this is one of them. So this is a PDF book called In Plain Sight that I believe 11 medical students participated in creating, and it was recently published through ACOG, which is the American Congress of Obstetricians and Gynecologic Surgeons. And as you can see, it's new initiatives, and it's I don't have pictures in it because they are very sensitive pictures, but it's for practitioners to use to be able to understand what disease processes look like in Black and brown women, since most textbooks typically only show disease processes on white skin. So how do you prepare for your well woman exam? So lots of things to talk about here. And the big thing is going in and understanding the time that you have with that physician or other practitioner. So is your appointment going to be 20 minutes, 30 minutes, an hour? And that's going to kind of drive what your concerns are. Right now, we're not talking about an acute visit. So this isn't that you have a symptom and you're going in for that. This is how do you deal with that annual exam that we recommend. So my recommendations are listed above. So I recommend that all my patients have a clear list of priorities. Oftentimes, we kind of hold off on things and concerns that we have, and I understand because accessibility to healthcare is very complicated and people have a hard time getting into their primary care. But oftentimes in those 20, 30-minute appointments, we most likely cannot cover more than 2 visits or 2 concerns per visit. So prioritize what your 2 concerns are and make sure that you advocate to get those answered during that exam. If you're seeing a new doctor, meaning you're switching, either you are transitioning out of the military and need to find a civilian doctor, or you're in between civilian doctors for whatever reason, recommendations are a couple different things. Number one, try to get your records to that clinic before you're seen by your doctor. This is very complicated. Again, I understand hard to reach clinics. I think the easiest way to go about it is if you can print out copies from some type of online medical portal. That's usually the safest way to ensure that you bring hand copies to your appointment. But you can also call your previous clinic and have them fax them to your new clinic. Call your new clinic, have them reach out to your old clinic to get those faxed. Or you can always drop them off at that clinic's medical records department. Most hospitals have them on the bottom floor of wherever you are, and they can get those things uploaded to your chart at your current location or your new location. If you have concerns about gender of the physician or chaperone, make sure you note that ahead of time. So very important when you're actually scheduling the appointment to tell the scheduler that you would like a female physician or a female chaperone or only females for your annual exam. It is completely within your right to ask for that. You may get pushback, and that is okay. You can just ask to talk to someone else at the clinic to get that scheduled. But it is within your right to request, if you're going to have a sensitive exam in a non-emergent setting, it is completely appropriate to request the gender. And then if you've had any surgery where any part of your reproductive organs have been removed, make sure that you let your physician and their staff know. So hysterectomy, if you had one of those where your uterus was removed, oftentimes that includes the cervix, but not always. An oophorectomy, which is when you remove the ovaries, or a mastectomy. Make sure that your physician knows before they start any type of exam. And the reason for that is you may not require the screenings that we would consider that you would need during that exam. So these are the routine questions that I typically ask my patients. I have my medical spiel, how I introduce myself, and how I go along this list. People, you may hear the words LMP. This is the first day of your last menstrual cycle. Very important for us to know, particularly if you have regular cycles and you've missed, that's when we may offer a pregnancy test. Or if you have irregular cycles, it tells us how irregular it can be. And then we talk about the details of your cycle. So are you having regular cycles, which is approximately every 28 days, can range from 21 to 35 days. All of that is within normal. How long do you bleed for? So how many days does your cycle last? And then when you're having your cycle, do you have excessive pain? Do you need to miss work? Are you unable to work out? Do you take any medication for your cycle? And then how heavy is your bleeding? This is a question that a lot of ladies cannot answer because we don't do a great job of knowing how well we bleed or how much we bleed. So I like to just put references. If someone's using any type of menstrual cup, that has the milliliters on it. So that usually gives us a pretty good indication. But different ways to word the question would be, how many tampons do you go through in 24 hours on your heaviest day? Or how many pads do you go through in 24 hours on your heaviest day? I always ask about contraception. Other word for that is birth control. So are you using it or no? And if not, it's my job to make sure that you understand if you're not using it, there is a risk for pregnancy if you are of reproductive age. So I typically follow that with, are you planning to get pregnant? And if that answer is no, that kind of takes us down a different path. But if that answer is yes, great. Then you're doing what you need to try to get pregnant. And then important to know about a history of sexually transmitted infections. I've listed them there for you. There's some confusion about bacterial vaginosis. I don't consider that a sexually transmitted infection. It is something that is essentially an overgrowth of bacteria that we already have in our vaginal canal that can change with new partners, can change with our hygiene practices, can change with all kinds of things, the environment in which you're in. So a lot of my active duty ladies would get BV when they've been in the field for a while. So that is not what I necessarily list under STIs, but some practitioners do. And to continue, are you sexually active? Yes or no? Usually I say sexually active in the last 3 months, just so you get a better idea of what I'm asking for. And then preferred gender of your partners, important for any testing that we may do. And then how many partners have you had in the last 12 months? That typically tells us if that's someone we need to offer sexually transmitted infection testing to that day. I often ask most of my patients, but if you've had multiple partners in 12 months, I want to make sure that you have a clean bill of health for any new partners that you may have. And then what routes? Oral, vaginal, rectal, and are you able to orgasm? This is something that's super important to talk about with your doctor if you aren't able to orgasm, especially being a survivor of sexual assault. There's that brain-body connection that's important to make sure that you're getting the resources to be able to get the pleasure that you deserve. HPV vaccine series completed. So yes or no. The most recent one is a 3-part series. A lot of, like my era, it came out when I was past adolescence, which is when we now recommend patients to get it for their kids or for themselves. So typically we give it between ages 11 and 14. But for a lot of us, we missed that window. So there's a lot of us who got maybe 1 or 2 and didn't complete the course. It used to be that we stopped giving it at age 26. About 2 years ago, it changed and you can still get it to age 42. If you have had HPV positive PAPs in the past, this might be something that's good for you to get to try to prevent you from getting any new strains. If you have new exposures and new partners and you're still under 42, that's another reason that you could consider either starting or completing that HPV vaccination series. And then PAP history, hopefully this is something that I would be able to find on your chart, but if not, it's important for you to know if you've ever had any normal PAPs and ever had a colposcopy or a LEEP. And I forgot to say this at the beginning. Nicole did a wonderful job introducing me, but I am not qualified to do colonoscopies. I'm qualified to do colposcopies. So I don't want anyone to think I'm doing colonoscopies. That is not something that I can do, but colposcopies is where we do biopsies of cervix. And this is when you have abnormal PAPs or a history of persistent HPV positive PAPs. And then the LEAP is that loop excisional electrosurgical procedure. And this is considered a definitive treatment for high-grade dysplasia that we typically find on the colposcopy biopsies. And then important to always ask about any history of assault. So I screen for both sexual and physical, particularly intimate partner violence during my exams. And then if the answer is yes, we talk about, do you understand what this physical exam and what this pelvic exam is going to entail? Is there anything that you need to be more comfortable during the exam? And then making sure that that person has the mental health resources and survivor resources available to them. And then we always ask about family history of cancer. In particular, in the gynecologic world, we're most concerned about cervical cancer, which is more than 90% caused by the HPV virus, uterine cancer, breast cancer, ovarian cancer. And then we also lump colon cancer in just because colonoscopies are a routine part of screening that we're also making sure patients are getting access to. So common complaints that could require a pelvic exam. So like I said, when you come in for your well woman exam, you don't necessarily need a pelvic exam. We used to do regular routine breast and pelvic exams on asymptomatic women that were just coming in for their exams. That's no longer considered evidence-based and can actually cause more harm than good. So the reasons that we would want to do a pelvic exam is if you came in for an acute issue, which were any of these, or if you came in for your well woman and as we were talking, you were positive for any of these symptoms. So pelvic pain, acute or chronic pain is greater than 3 months. Acute pain, the importance of this is to make sure that we can hopefully isolate where that pain is. And then we want to make sure we take a look at the cervix and know if that looks inflamed, irritated, has abnormal discharge coming out of it. Intermenstrual bleeding. So if you are a person who typically had regular monthly cycles, and then you're suddenly bleeding in between cycles and you haven't changed anything, meaning you haven't started any new birth control, you haven't started any new medications that could possibly alter your menstrual cycle, this would be a reason to do a pelvic exam. And the reason for that is we like to make sure that we rule out structural causes of it. And something that I wouldn't say is common, but that we've definitely found before and is important to rule out is a polyp. And those can be on the cervix or coming from the uterus and protruding through the cervix. If you're bleeding after intercourse, especially on a regular basis, that's something concerning for an abnormality on the face of the cervix. Vaginal discharge, so there's normal versus abnormal. And if you have a complaint of abnormal, your discharge has changed since you were last seen by a doctor, that could be a reason to do a pelvic exam. If it's just abnormal vaginal discharge without any other symptoms, you could probably just self-collect. And so that's always something that I like to make sure my patients know about. So for you guys to make sure you advocate for, if you don't have pelvic pain and there's no other concerns and you just have a change in discharge, it is completely appropriate to ask to self-collect and do your own vaginal swab instead of undergoing a speculum or pelvic exam to collect those samples. Vaginal itching, oftentimes this is related to yeast, not always. So typically we don't always do a pelvic exam for vaginal itching, but if it's on the outside of the vulva and not within the vaginal canal, then we typically do because we would treat it differently. It'd be, excuse me, we would treat it, we would want to make sure that it's not another dermatologic condition on the vulva that could be more sinister, such as a precancerous lesion on the vulvar skin. But if it's vaginal itching that's within the canal, oftentimes we can just give you medication for a yeast infection without having to do an exam. And then dyspareunia, this is also known as pain with intercourse. This can require an exam. It doesn't always have to, but something that you could consider. And then dysuria, so pain or burning sensation with voiding or peeing. Typically, we collect urine and we consider cystitis, which collecting the urine will tell us if it's a culture positive, meaning that we found a bug in it, meaning you have a UTI or urinary tract infection, or if it's culture negative and there's another cause for you having that burning sensation when you pee. And then urinary incontinence. This is important, especially with women who have had vaginal deliveries before. There's pelvic floor changes that occur. You have pelvic floor weakening after vaginal canals, and that can lead to all kinds of incontinence. Most commonly is stress incontinence, where you have a leak when you sneeze, go run, heavy cough. And the reason a pelvic exam can be important is because we can identify where the prolapse is. So is that prolapse coming from the bladder? Is it coming from the uterus? Is it coming from back along the rectum? And so a pelvic exam could be helpful with that complaint as well. And then I put pap screenings at the bottom because obviously you need a pelvic exam to collect the pap sample from your cervix. So components of a pelvic exam. I assume that most everyone here has had a pelvic exam before for at least a pap. So we start with our external exam. Usually the external exam is just visual, but if you have some type of vulvar complaint, we may separate the sides of the labia or the portions of the labia and try to find the concern you're talking about, whether it's a bump, whether it's redness, whether it's some type of irritation. So things we're looking for are anything that's abnormal, different, and then a big component is whether you shave or not. And that's not because of the exam, but it's because shaving can lead to some of those irritations and some of those symptoms that you may have. So it's important for us to look on the outside and determine, is it based on a symptom, or is there something there that we need to treat and kind of take a little bit more seriously? And then speculum exam. So here's our speculum. We typically, this is, you'll see a green one. So green is kind of the average size, but all your clinics should have different sizes. So sometimes we need to adjust and use different sizes. Some require longer, some shorter, some thinner, some thicker plastic walls. And so it all is kind of based on when we start with this normal one. Is it too painful? Is it not working? Are we not able to visualize what we need to? And we may adjust and grab a different size cervix or different size speculum. And then there's the bimanual exam. The bimanual exam is what I was talking about previously. So, or bimanual exam, I'm sorry, is a exam that we do after. And this is only if there's a reason to do it. So a bimanual exam is not warranted or indicated in a routine pelvic exam. However, if you're having a specific complaint, most commonly pelvic pain, the bimanual exam can help us determine the location of that pain. So right side, left side, cervix itself. It helps us rule out pelvic inflammatory disease, which can be caused by a lot of different things, but most commonly gonorrhea or chlamydia. And then often we do a bimanual exam to check for the orientation of the uterus before we place an IUD or do any procedure where we would have to go into the cervix and through the cervix into the uterus. So also sometimes bimanual exams are important for endometrial biopsies. So how do we, or I as a provider, ensure respect for your past experiences? So a little bit we talked about before, but safety and trust is paramount. You have to make sure you listen to your patient in the minutes that you have with them, and you ask very specific questions about their sexual assault and physical assault history. Also, clear and transparent communication. Part of that is making sure that you perform informed consent, even if it's just verbal. There's typically no type of signature for informed consent required unless you're doing a procedure. But it's important to make sure that the patient understands what you're going to do. So if you're going to include a bimanual exam using your gloved hand and lubrication after a speculum exam, your patient needs to know that and be prepared for that. And then also ensuring that a chaperone or standby is present before you begin any type of exam. Also, avoid triggers. I think in general, we should all be doing this, not just in a doctor's office, but in particular to us, it's important to make sure that we use terminology that feels safe and secure. And so we try to avoid any sexual terminology, any animal terminology. So for example, the footrests are footrests, they're not stirrups. The thing that you're covered with, we call it a drape or curtain. We don't call it a sheet. We call the table in which you're lying on a table, not a bed, because we're trying to make this location neutral for our patients. And then also physical touch is really important during the exam. You have to touch your patient, but they need to know where you're going to touch them before you do it. You should also, I know a lot of women have had this experience before, but sometimes physicians get impatient and they try to push people's knees out, let your knees fall. You should never be pushing a patient's legs. You can help, and what I typically do is tap the outside of their knees, and I say, try to let your knees fall to the outside. If they need help getting their feet into the footrest, I can help maneuver their feet, but you should never push from the inside or from the groin towards the outside. You just direct your patient what would be best for them to do for the exam to be as smooth as possible. And then aftercare, hopefully all the clinics that you've been to provide wet wipes, tissues, pads, and then talking through what to expect. In our clinic, we typically have checkout sheets. So if there was any labs that you did, anything that they need to do to after the exam, or if there's any follow-on testing that they need, write that down for the patient so they know they don't have to forget. Because if you're talking through an exam, patients aren't listening during a PAP exam. They're just breathing and trying to get through that moment. Alternative positions available. So this is something that most women are not offered. I would say most physicians don't even think about this unless you're focused on women's health as maybe an OBGYN or family med. But there's all different kinds of positions that you can use to make a patient more comfortable during these types of exams, whether it's a bimanual exam, rectal exam, PAP exam. This is an example. This is actually from, the image is from an article that was from, I think, 1982, that shows all these different variations to complete the speculum exam or the pelvic exam. I think an important one to note is you can adjust your head. So if you don't want to be completely flat and you want to be up a little bit, whether because you have back pain or you want to be able to better understand what's going on and be more involved in your exam, it's completely appropriate to adjust the head of the bed for the exams as well. So how do you stop an exam? You tell the physician to stop. That should be the bottom line. But I wrote a couple of examples if you are not able to say stop, or you freeze, or you have another type of post-traumatic reaction that's not allowing you to say the words you need to stop. These are other ways you can do it. You can say, this is too painful, I don't want to continue. Can we try different positioning? And you could even offer something that you just saw on the last slide. You say, I'd like to stop today. Let's try again a different day, and stop. But ultimately, if you ask a physician to stop during a physical exam, they should stop. And if they don't, that is the reason the chaperone is in the room. So this is not part of the pelvic exam, but I just wanted to put some additional components of a well woman exam on the screen so everyone could be aware of kind of things to make sure that you're getting and that you are up to date on. So PAP screening, I'm of the era where I was getting it every year. That is no longer required. It could be required for some people if you have repeated abnormal PAPs, but typically we start routine screening between ages 21 and 25. Currently, the American Congress of Obstetricians and Gynecology recommends 21, but the American Cancer Society, or I might be saying the wrong one, but the oncologists and their association recommends 25. And that's for a number of reasons that we don't really have time to go into today. If you are not sexually active and someone is trying to have you do a PAP exam, it's important to explain that you haven't had any sexual activity and you could delay yours. In the military, this is really hard to do because we just assume that this is routine, this is what we have to do, and we do it. But it's very, very important to advocate for yourself. So if you have not had sexual intercourse and you are over the age of 21, you do not need a PAP until after you have sexual intercourse. And I would urge you to get the HPV vaccine so you're covered from the 9 most common strains of HPV that can cause cervical cancer before you even start having any type of sex. But as the age changes that were recently made, kind of use 30 as a cutoff. So we have some recommendations for ages 21 to 30, and then we change the recommendations for women 30 and older. And typically, if you're 65 and you've had no abnormal PAPs for at least 25 years, you can stop at age 65. If you've had abnormal PAPs within the last 25 years and you are age 65, then that would be a discussion with your physician to determine if you still need to continue beyond age 65. For mammograms, routine start age is 40. And then you'll see different guidelines. Some recommend every 2 years, some recommend every year. And if you have a history of breast cancer in the family, it's important to discuss that with your physician because we would likely recommend an earlier start date for you based on who in your family had breast cancer and at what age they were diagnosed. For colonoscopies, there's been a recent change with this as well. We're now starting at age 45. Before it was 50. This was approximately 3 years, I believe, 3 years ago, we made that change. Colonoscopies are life-saving and I highly recommend them. There's also an option to not do colonoscopies and do different types of screening. So Cologuard is something that you could ask for. You do have to do the Cologuard more often. So a normal colonoscopy essentially gets you to 10 years before you would need another one. With the Cologuard, if it's normal, you would require it every 3 years. So you would have to be screened more often, but it's much, much less invasive. And it's a good option if you have fears or concerns about a colonoscopy or going under anesthesia for any reason. And then there's DEXA bone scans. So this is routinely started at age 65, but if you have any of a number of risk factors for osteoporosis, we may start it early. And then typically we would redo the DEXA scan every 5 years or as needed based on your history. And then I'm a big proponent for vaccinations. So I just wanted to make sure everybody understood age recommendations for certain vaccinations. So shingles is recommended at age 50, also called Shingrix. Influenza yearly. I know that my hospital just got ours last week, so I got mine this week. Tetanus every 10 years. That would change if you have some type of issue where you had an injury or a bite or something like that. PCV20 is the newest form of the pneumococcal vaccine. You may have had or heard of PCV, well, there's two different, but pneumococcal 13 and 23. Now the PCV20, if you haven't had the others, is a one-time pneumococcal instead of a two-part series. And then COVID and RSV. And then STI screening, we briefly touched on this, but the recommendations are annual gonorrhea chlamydia testing for any woman 25 or less. And the assumption is that people are not necessarily well educated in safe sex practices. So let's make sure, and ultimately gonorrhea and chlamydia untreated can lead to infertility. So we like to make sure that we check annually to protect against something progressing where it could cause infertility. And then we like to make sure that we check at least one time in everyone's life for HIV and for hepatitis C. And then the rest are typically just based on exposure. So if you have any concern that a partner had any type of STI or you're having any type of symptoms, you just come in and ask for a STI panel. And then here's a number of resources that I've found useful with sharing with patients. So Planned Parenthood, I utilized that when I was in the military before I was a doctor because I didn't trust the military system. And I urge anyone that is avoiding care in the military or in a certain location because they don't trust the system or providers, Planned Parenthood is a good alternative to make sure that you get the care that you need. Family Justice Centers, so this is for survivors and families of intimate partner violence. Healthywomen.org, and then they have a little bit of a break off called military.healthywomen.org. It's a lot of patient stories, sharing symptoms, sharing disease processes, sharing how they cope with so many different things. And the target audience is women's age 35 to 64. And then ohmygodyes.com is a great new website that I found actually on Instagram. And it's non-medical, but it is a group of women who came together to essentially focus on intimacy and pleasure for women and making sure that people had resources to get the pleasure and attain the pleasure that they deserve. And I realized that I just forgot all the prompts. So I am so sorry. But that is the conclusion of my presentation, and I'm happy to take any questions at this time. Or if anyone wants me to go back to a certain slide to show any images again or talk through anything that's related to a question that you have.
I would like to ask a question.
Yes.
I know you mentioned being an advocate for getting shots and making sure we are up to date with our shots. And you mentioned the HPV. I recall when I had my kids when they were young, they're 20 years old now, but the doctors warned us, make sure that they get their HPV shots because there's a window for age-wise when it